Hey guys, welcome to another episode of Tech Tuesday. I have Katherine Kim with us today, who's doing a lot of really interesting work. I would add that we met at CES back in January. This is probably for about the sixth time. I'm going to say I think this is the last person from CES, but we're only like 2.5 months until CES happens again, and so I assume it'll be like this next year or maybe more. Welcome, and before we get started, this. Hey guys, Steve Moran here. So, Katherine, let's just start with a little bit about who you are, what you're passionate about, what you're working on.
Great. Thank you so much, Steve. It's nice to see you again. I'm really excited to be here. So I'm Kathy Kim. I'm the founder and CEO of HealthTequity, but my background has been in healthcare my entire career. So over 35 years in healthcare. I've worked in hospitals, medical groups, clinics, on the operations side. So I used to run these practices that I'm trying to help now. I moved into tech and became a developer of products and had previous startups. And then moved into academia, and I was a PhD prepared academic researcher, professor at UC Davis, University of California, Davis, and try to combine all three of these things to really address what I care deeply about, and that is supporting the collaboration of patients and families with healthcare systems so they can be the best, have the best health and well-being possible.
So this is an area I'm super passionate about. I'm 70, which means that I'm interacting with my healthcare system more. I'm managing the care for my 92-year-old stepfather who has dementia, who's on hospice in a residential care home. And the thing that strikes me about how human beings interact with healthcare systems is that everything that the healthcare system does seems to be designed for the convenience of the healthcare system and not for the patient or the consumer. Is that a fair statement?
I think from the healthcare system perspective, they're designed for reliability, safety, right, standardization, because that's how they know they can deliver care the safest and most reliable way possible. That means that it's not necessarily personalized to what each patient needs or what each family needs. So in that sense, it can feel like to the patient and family that this is not for us. This is not delivering what we need. And I think that's the essential tension between healthcare systems and patients and family members.
And so tell me a little bit about more. It sounds like you're working on making that better. So talk to me a little bit more about what that looks like.
Yeah, so HealthTequity is a startup. We started in April of 2024, so we're just barely a year and a half old. But we developed technology that came out of a research project. So I was still a professor at UC Davis, and I worked for MITRE Corporation, which is a nonprofit research and development center. And then we collaborated with the UC Berkeley campus as well. And we built a system to try and address what was happening during COVID. So we started in 2020. And community clinics were having to close their doors. People were afraid to come into the doctor. They didn't have any capacity to do telehealth or any kind of remote care. And so they were really kind of closing their doors, trying to figure out how to maintain care for their patients. And this was really important for people with chronic illness because they need this ongoing care. So we came in to see if we could build a system to help these community health centers do this. And for people who might not know, community health centers are the primary care service providers in most of rural America, as well as in communities where people are low income. They may have Medicaid or they may not be insured at all. So these these healthcare centers are really the main provider of primary care for the low income, under-resourced, and rural communities. So these are critical providers in their communities.
So, and they're mostly staffed with primary care physicians, nurse practitioners,
physician assistants,
PAs. Yeah.
Exactly. There are very few, as we know, we already have a shortage of physicians and nurses, nurse practitioners. So community health centers have an even harder time keeping themselves staffed. They do rely a lot on medical assistants and community health workers, but even those positions are hard to fill. So they really have staffing challenges in addition to having lower resources than private health systems or larger academic or urban health systems.
Okay. And so how do we make it better?
Yeah. So what we set out to do was actually create a system that would allow the community health centers to streamline the care they provide to patients with chronic disease. And we started with diabetes and hypertension that would bring the best of the digital health technologies that were already available in the market. They just weren't available to these community health centers. So we integrated remote monitoring devices, things like glucometers, blood pressure scales, or blood pressure cuffs, weight scales, the things that people could use in their homes if they can afford them, and bring that data directly in to the clinic and to the provider, and then allow them to see all this data for their entire patient population in an easy to use system, even before it goes into the electronic health record. That allowed them to very quickly see the status of all these patients, understand who was trending, whose vital signs were trending positively or negatively, and really be able to target who needed intervention more quickly than others. So they were able to efficiently reach out to patients with diabetes and hypertension and address their needs in the moment via telehealth, so that they didn't have to rely on people coming into the clinic during that time. Well, it turns out that that's a really efficient and effective way to manage chronic disease. We know that from lots of research studies. It just wasn't available in these communities.
And so is it more, I mean, it sounds like that should be good for everybody, not just low income people, right?
Absolutely. And that's where a lot of the research shows in a number of studies, if you use these connected devices where the patients know what their information is. So is my blood pressure good right now? Was it, good in the morning or last night? And how I ate today, is that changing my blood pressure? Same thing with blood glucose for people with diabetes. So people in the moment know what their status is and what their own activities are doing to contribute to either good or bad blood pressure or glucose. That information is sent immediately to the provider and to the medical assistant or nurse, and they can see it as well. So that access to the information right away about what's happening in the body related to those conditions allows you to help people say, what do I need to do today? What's the step I can take today?
Okay, and so beyond sort of a communication portal between healthcare providers and individuals, what else? And I'll give you an example. I hope my wife, she's not listening. She's in the other room, so she might shoot me for doing this. But I'll give you an example with her of, and this is the kind of thing where it just feels frustrating. So she's had what looks like a pimple right on the end of her nose, and it's been there for weeks. And she'd touch it and it would bleed and it would never get better. And we were talking about it over the weekend. And she said, I just don't know what it is. And I said, well, have you Googled it? And she said, yeah, and it's not very helpful. So I sat down with AI, and I use AI a lot. And so I spent sort of 5 minutes writing a prompt, putting quite a bit of detail in about what's going on, what's going on with her nose. And I pushed the enter button and immediately popped up and said, oh, that's almost certainly basal cell carcinoma. And it's the least dangerous kind of carcinoma, but it needs to be looked at. And, in a minute you say, oh man, cancer, that's bad. But on the hand, wait a minute, lots of people have basal cell, it's not really that big. I mean, you need to treat it, but it's very treatable. It's not a life-threatening moment. So she reached out and she said, well, should I tell the doctor? And I said, oh yeah, the doctor won't care. So she sent her a message to the doctor, and like 5 minutes later, the doctor said, oh, I got to see you. Let's do a telemedicine. But you're probably going to need to go see a dermatologist. And so she'll do a telemedicine tomorrow. She'll get sent to the dermatologist probably next week or the following week. And I assume they'll go in and cut it out or freeze it or something. But that seems really inefficient to me. I mean, is there a way to make that better?
There is. And here's here's why chronic illness is different from some sort of immediate need, right? This is not something your wife deals with every week, every day of her life. This is a one-time situation that she wasn't sure what it was, didn't know what to do about it, didn't know what to do next. And so having access to someone who knows how to Google it, or someone who knows how to search AI, at least to come up with some ideas about what to do. Having access to healthcare, you've got health insurance, you've got access to a primary care physician,
Right.
You're able to schedule a telemedicine visit. You obviously have a computer with a webcam and speaker. You know how to use, telehealth. You could do that. And then a referral could happen. So already the first 3 steps, you already had access to it. Your wife already had access to it. The issue is, and so it could be more streamlined, but just take access from the beginning. Many people don't have those first 3 things, right? Even if you don't have to be low income, you could be high income, but you've just never interacted with this kind of technology before. You might still default to, let me try and call my doctor. Let me ask someone in my family, do you know what I should do about this? Let me call my neighbor who works in a hospital. Many people are using the resources they have to get the information they need. Now, let's move that to a chronic illness where these things happen every day and every week and every month and are likely to go on for the rest of your life. What do you do each day? If you don't have symptoms, you might not take any action, right? Many people with diabetes and high blood pressure don't have any symptoms. They're there thinking, I'm just going along fine, until it's gotten so advanced that there's some other kind of complication, organ damage, something more severe that happens. And so the key with chronic illness is to prevent it from getting to that place where it's an urgent situation or a crisis situation. That's why you need regular monitoring data, so people know what they do every day, how it affects their underlying condition, and how they can keep it in check so it doesn't progress to that point where you have to do something urgently. So one of the ways, let me just make sure, one of the ways to streamline all of this is to make sure that people have a baseline access to the technology they need, and to the resource, whether it is insured or uninsured, the resource they need to the healthcare professionals who can help them make the right plan of action.
So the dream would be, I've got blood pressure cuff, scale, maybe a Cardia app to look at my heart, and that every morning when I get up, I spend 5 minutes and I plug myself into those things. That information all goes into the cloud someplace, and the cloud is looking at that and says, oh, Steve looks fine today, or Steve needs further intervention, in which case it goes to a healthcare provider.
I don't think we need to over instrument ourselves. We don't all need to have 3 or 4 wearable devices, electronic devices monitoring everything we do.
Oh, yeah, wearables too, right?
Wearables.
Yeah.
Absolutely. We don't need to over instrument ourselves. I think where we can start are people that we know already have chronic conditions that would benefit from monitoring. Diabetes and hypertension are the 2 most prevalent ones. We know that it's a problem that people who even people who know what they should be doing aren't necessarily doing those things. So we've all been told, lose weight, eat better, sleep enough, get physical activity. How many of us actually do what's recommended? Very few. And so we can address the people who we already know have these conditions with these kinds of programs, with devices, with access to a health coach, for example, access to telemedicine. We know we can manage these conditions because there's lots of research that says we can manage these conditions. Now you can start to move upstream. For people we don't know, we know that now pre-diabetes estimates are just off the charts. So people who don't have diabetes yet, but they're on the cusp, we can be moving upstream there to prevent them from getting diagnosis. For older adults in particular, we know chronic illness is much higher, has much higher prevalence or much higher rates as people age. So we could be monitoring them regularly if they don't have these conditions yet. As they start to age, in middle age and older, we could be monitoring them very easily. And at the point that we start to have concern, we can easily say, get a Google Watch, a Samsung Watch, an Apple Watch, get an Oura Ring, get one of these devices that gives you some early warning signs, right? Just to monitor. But the other thing is, think about women's health. there's so much going on in women's health, and particularly in midlife and older life, where we just don't have any data. It's not routinely connected in hospitals or in physician offices about women's symptoms, about signs, about what cluster of these indicators would actually suggest a serious condition or one that can be managed. On sort of opposite ends of the spectrum, it could be as simple as you are in perimenopause and we can consider some lifestyle management, all the way to, as you said, it could be cancer, or it could be fibroids, it could be lots of other things. But if we don't track these things on a regular basis, many women just manage, think that this is just a normal part of my life. And so they're not able to take action. So it's using the technology judiciously. And when we do have devices that people are using at home, getting that data to their healthcare providers so that someone can make sense of what's going on.
And is that what your platform does, is basically collects that data and gets it to the healthcare provider?
That's the first thing that it does. So
Okay.
we integrate any commercially available device if it can be connected via Bluetooth or cellular, and we do both. So any commercially available device, we don't sell you the device. So you can use anything that's on the market. We will integrate it, and that data can be then sent back to you in your app. So if you have multiple devices, you now have it all in one place. And then we bring up an easy to use dashboard for the provider, and we'll integrate it into electronic health records so that that whole workflow is streamlined. That's the first thing. The second thing is, now you've got all the data. What do you do with the data? Right? People don't want to just see a mass of data points. They don't know what to do with all these data points every day, multiple times a day. The providers don't want to see every little data point. What people want to see is some sort of analysis that tells me, where am I trending, right? Am I going up or am I going down? Where are the points where I need to actually pay some attention? Like, what's going well? Where are the points that I need to pay some attention? So that's what we do in our app and in our dashboard. We provide those analytics based on what clinicians say they want to see. So we do want it to be part of a relationship with a clinic or a doctor's office or a hospital, so they can decide what the priorities are, what the parameters are. We don't make those decisions for them. And then we can bring that information in an easy to use chart, graph, bullet points, so that people know what to do next with it.
So I'm sitting here and I'm thinking, I've got a Fitbit. I've got a Samsung watch, which is actually Samsung ring, which is actually broken, and should be out on warranty repair. Should have back next week. I've got a smart scale. I've got a blood pressure cuff. I don't think it's actually connected, but I could be easy to go get one that is connected. So could I just say, okay, I'm going to go plug all this thing in and monitor it and see what it says?
Yeah, with us right now, we're only marketing it through clinics and doctor's offices and hospitals. So your provider organization would actually need to be enrolled with us for us to do that. At some point, we might go direct to consumers, but that's a more difficult challenge for us in terms of marketing and distribution and things like that. So for your provider organization, they could say, for all of our patients, these are the 10 different devices we think they most commonly have. Would you integrate all of those? And many of the ones that you mentioned, we already have, but that would have to come through your provider organization right now.
Okay, so are you using Sutter? I got to ask. I'm very curious.
We don't have Sutter. If you want to
introduce Sutter, we'll do it. You got to work on that. So, got to work on that. So,
yeah.
So I want to shift a little bit and talk more broadly about technology.
Can I add one thing though, Steve, before you make that shift? Could I add one thing?
Yes.
Yeah. So the last part of our platform is actually our AI capabilities. So we have 2 AI capabilities that we started developing this year. We've been funded by National Institutes of Health with 2 different grants to do this. The first one is a multilingual AI agent. So for people who want to use the app in a different language, or people who might have a little bit of challenge with their eyesight, and so they can't see on a small screen what's happening on their phone or even a tablet, or have some challenges navigating with their fingers, these apps that require holding and swiping and things like that, you could navigate our software with your voice in English, Spanish, and Tagalog. So
Cool.
it's not just translating what it says, but it's actually taking your voice command and navigating the software itself with your voice, and then returning whatever information or response back into your language. So that's one. That's how we're using AI. The second is called a digital twin. And what a digital twin does is take all of these data that we've collected from clinics, from their electronic health records, from the remote monitoring devices, from their payment systems, and put it all into an AI engine that helps us predict how their disease is going to progress. Not only how is it going to progress, but also if you were to change an intervention, for example, change a medication, start a new remote monitoring device, start health coaching, or remove those things, or change the health insurance, how can you predict that that would affect the progression of your disease? So that digital twin is the second piece of AI that we're developing. And with these two pieces, we're really hoping to make care coordination accessible to populations that don't have it now. These are the older adults served in the community. These are rural communities, under-resourced communities, low-income communities. So to bring these kinds of AI tools to the communities that don't have them, where the other larger, well-resourced private academic medical centers, they're already able to use these kinds of tools. We want to bring those to everyone else.
To me, this is so exciting. And you say, well, the well-resourced centers have all that stuff. And my response is, yeah, I guess. I'm Sutter. Sutter is a sophisticated system and throughout California, huge system. I don't have any of that stuff.
I guess that's true. Yeah.
I mean, I had some blood tests done several months ago, and I had a couple things that were a little bit high, and it said it's a little high, and the doctor sort of casually said, "Hey, don't worry about it." But I worry about it, and so I took all that stuff and I downloaded a whole bunch of historical reports, and I dumped it into ChatGPT and said, "Okay, tell me what I really need to know." And of course, it said, "Don't worry about it," too. But it gave me enough information, and I'm looking at this stuff, and I'm thinking, I could so much better manage my health, and I'm pretty aggressive about managing my health if I had that AI, and the capability is already there. So I think you should be doing this for everybody. Maybe you should be letting the people who've got resources help you pay for the people who don't.
I'd love to hear from those people that got the resources.
Because I'm thinking it would save my doctor so much time and so much.
Absolutely.
Sort of, pet peeve, right? Doctors got to release test results before you can see them. No, why don't you just make it so that as soon as the lab uploads them in the system, I get to see them? So anyway, So I want to shift a little bit to senior living for just a minute. When you think about designing new technology, and I'm going to think specifically senior living, what is sort of one design sin that people have more common than any other?
I think it is paternalism towards older adults. It's the idea that technology should let somebody else monitor an older adult because they can't take care of themselves. Or somebody has to, be the gatekeeper over the older adult. In some circumstances, of course, that's going to be needed. Some older adults really need, a lot of support, but that's not the case for everybody in senior living. And so I think that we should be designing for personalization that fits what each individual needs, not assuming that we need to, provide oversight over an individual rather than empowering them to be their best advocate.
So I love that. I'm actually working on a post that's sort of along that lines right now. Somebody posted on LinkedIn something about interacting with, they didn't use quite the words, but here was the effect was interacting with some cute 60 and 70-year-old people. That puts me in that category, and it makes me feel a little bit like a zoo animal. So I think I can still handle my own stuff pretty well. So let's assume that you had 6 months, $100,000, and you were going to run a minimal pilot to figure out ROI. How would you do that?
Yeah. So this is actually kind of what we had when we started this project that led to Health Equity. We started with a co-design project with Community Health Center, with their providers, their staff, their medical assistants, health coaches, the patients, family members, and community members who weren't even using that clinic. We brought together 25 individuals over 6 months. This is in COVID, so we were not in person, unfortunately, but we were on the phone every day. We were in conference calls, video calls, everything with them. What co-design means is that you work together as a team. You try to understand each other, understand the real problem you're trying to solve, not the one that you as the designer or researcher assumed what needed to be solved, but the real problem from the perspective of your stakeholders that needs to be solved. And then you solve for those challenges. We combined that with the agile software development approach, which is like every 2 weeks, you say, here are the set of problems we're trying to solve for. We're going to do a sprint and build the software to do these things. And then you go back to your users and you say, okay, test this out, try this out, do this, let's change it, let's adjust it, let's refine it. And every 2 weeks you're doing this. So that was the approach we took. In 6 months, we went from concept to go live through this co-design approach. And that's embedding yourself together as a team, both the researchers, designers, technologists, and the stakeholders and users, making yourself part of an actual integrated team to solve on the fly, to build and design and test and iterate as you go, so that at the end of 6 months, you don't have to fix all the things that you made assumptions about because you didn't check with people. So the first thing I would do was launch co-design. Okay, so let's assume we've done that, and we actually did that in 6 months. We now have our system, and we said we'd like to see if this can work in real life and achieve health outcomes and ROI in 6 months. And we actually did this. So we launched the system in one clinic. We enrolled over 200 patients, both diabetes, hypertension, or both, with the medical assistants and community health workers in the clinic serving as the primary coordinators. So they were the ones interacting with the patients. They enrolled the patients. They monitored the data coming in, and they already were working with those physicians and nurse practitioners. So they were the primary point of contact. And they talked to the patient at least once every 2 weeks. So they're getting the data in from the remote monitoring devices. They talked to the patient. They checked in at least once every 2 weeks, more often if the patient wanted it. And they monitored how the hemoglobin A1C and blood pressure was progressing. They talked to the doctor at least once a week, because patients were not coming in for visits. So they talked to the doctor at least once a week to review the whole group of patients and to see what clinically the doctor wanted to do, if he wanted to make changes, he or she wanted to make changes. And then we tracked the outcomes. In 6 months, we got both the majority of our patients with diabetes and hypertension in control within 6 months through this approach. We estimated what that would save the healthcare system. And we estimated for diabetes, it was 3.7 points reduction in hemoglobin A1C. That was the equivalent of over $300 in cost savings, just based on A1C reductions to the health system per month, per person, per month.
Wow.
For blood pressure, we got 20-point reductions in systolic blood pressure. That's what drives the cost in healthcare. That reduction would save over $200 per member per month to the healthcare system. So we actually did this study.
So why isn't we're running out of time, but I have two really important questions. So first off, why isn't everybody doing this? Not for everybody. That's my number one. And the second thing is, I know there are some CCRC operators out there who have budget, who would look at this and say, I got to have, this could make a huge difference in my resident population. Longer lengths of stay, healthier, less hospitalization, less hospital readmission. How do people get involved?
Well, we would love to take any calls, any contacts from people that that would like to try this. I think the reason there are places where it happens routinely. At Kaiser, this happens routinely, right? There are more integrated systems where it happens, where you can get the insurance to cover these devices. You have the health coaches and digital navigators to make sure that each patient can use it. and you have an integrated workflow for chronic disease management and what the physicians do in their daily visits, right? That has to be an integrated workflow.
Right.
That takes an integrated system. So we're not
Yeah.
all integrated that way.
Yeah.
But we do think there's a huge ROI and value proposition for anybody to do this.
Yeah.
And because we're a startup, we just started back up in January. We don't have a big marketing team, but we'd love to talk to anybody who wants to try it.
Cool. This is really exciting stuff. I mean, to me, it saves money, it makes people's lives better. I look at it and I think I could better manage my own care. I'd have early warning if things were going wrong. There's almost, I mean, you haven't really used the term, but almost some gamification in there to maybe make me eat less and exercise more, right? So all those things could be super valuable. Thank you so much for joining me. This was great conversation. I hear stories like this, and I'm so encouraged by what's possible as we look at our healthcare system that's just overburdened. So again, thank you very much.
Thank you, Steve. It's been a pleasure being here. And if anyone's interested, please come to our website at healthtequity.net, and I'd love to talk to you.
Cool. Thank you very much.